Ladies and gentlemen, dear colleagues, dear friends, welcome to this new session of the EKS Hot Topic, which tonight will be dedicated to knee revision. The number of revision TKA is growing every year all over the world, and its counterpart, the rate of re-revision, is also growing very fast. And this demonstrates that revising TKA is still a challenge, particularly for the fixation. In the 80s, all the reconstruction were done from epiphysis to diaphysis. In the 90s, all the reconstruction was done from the diaphysis to the epiphysis. And it's only in the last decade that we discovered that the key is in fact the metaphysis. And this opened the door to a new concept of zonal fixation. And tonight we are very happy to have a Professor Fares Haddad to detail all that concept to us, and he will be challenged by Professor Van Element from Netherlands and by Professor Andrea Baldini from Italy. Thank you very much.
Michel, thank you, and good evening, everybody. It's a great privilege to be with such great company this evening. I see my role very much as setting the scene with Professor Van Hellemond and Professor Baldini, really fleshing it out to the direction that we're going in here and the importance of zonal fixation and revision knee arthroplasty today and for the future. These are my disclosures. They are always relevant. I don't think I'm going to veer off track in any major way tonight, but please do bear them in mind because this is an area where industry has been incredibly active in the last decade and will need to continue to be active if we're going to get better at making revisions work, because we still have some unanswered questions. Michel has already put the great and very important context here, is that revision knee arthroplasty is not a straightforward thing and has a high failure rate. And we need to think that this is not a repeat primary. It needs much greater thought, much greater planning, special techniques, and indeed special implants. So the whole process and the decisions around it can be complex. And at the heart of that, I think fixation and getting durable, long-term, if possible, biological fixation is key. So that's why I think this zonal fixation concept is important. It's certainly changed our practice, and I think it's something that needs to continue to evolve. So I'm pleased that it's being reevaluated. I can tell you that we had a meeting focused primarily on this in New York earlier this year, through which many of us were at, and I'm hoping that that meeting, this discussion, and many others will generate a greater energy in this area and more work to develop fixation in revision knee arthroplasty. At the end of the day, I think we all recognize that bone loss is the key that we're dealing with. And this is both the predictable bone loss, such that you see here, but also the unpredictable bone loss that sometimes faces us when we are in the middle of a revision knee arthroplasty. There's no question that bone loss guides reconstruction, but I think we've got to take a little step back and also consider that, as well as the femur and the tibia, where I'm going to focus today, bone loss in the patella is a whole other topic that we can really discuss, and that isn't encompassed in the zonal fixation concept. We've also got to remember that beyond these zones that we're going to talk about, some defects are contained and some uncontained, and that too is of relevance as to what you're trying to achieve and what your ultimate construct will look like. So I think bear those things in mind as a backdrop. I think one of the things to start with is, if we go around the world, the classification system, which I think is now out of date, but the one that everybody still looks to, is the Anderson Orthopedic Research Institute, or AORI system. And that breaks it down into three types. Type 1, where essentially we've got an intact metaphysis and an intact joint line. These are really the very straightforward cases. The type 2s, which are the majority, where we've got damaged metaphysis and some displacement of the joint line. And then the type 3s, which are massive, with a kind of loss in that so many of our cases are lost within type 2. So these are the type ones, and these are frankly straightforward revisions if there is such a thing, where we can use a standard implant and usually plug gaps with cement if you are indeed still cementing your knee arthroplasties. The type 2s are the big focus, where we have, I think, migrated away, not completely, but largely from bone grafts and augments more towards the use of cones and sleeves. And that's been a positive move, but it's one that will continue to evolve. And then there's the type 3s, where really the whole world has collapsed. Everything's gone horribly wrong. You've lost the entire metaphysis. You've got insufficient ligaments. And that's a complex reconstruction situation. But I hope I've illustrated the big jump from 2 to 3 that perhaps that the modern discerning surgeon needs to work his or her way around. This is nothing to do with the fact that Professor Van Hellemond's on this call. I would like to plug this paper and this classification. I think as a group of revision knee surgeons worldwide, we need a common language that we can agree to communicate with. And in terms of bone loss in the knee, this probably is the one we should land on. I'm happy to hear from the others later and see if there are other recommendations and thoughts. But my advice would be, this is out there and maybe not everybody agrees with it, but this is better than what came before in terms of looking at knee bone loss. This is the subdivision into the zones. I'll come back to our zonal paper in a second, but this mirrors exactly what we were thinking, but describes it in a very clear way, using the adductor tubercle, the widest part of the fibular head, as the junctions, if you like, between metaphysis and diaphysis on both sides. So I would really commend this piece of work for you. And for those of you not familiar with it, what it does is it goes into each of those regions, the epiphysis, the metaphysis, and the diaphysis, and breaks it down into no bone loss, mild bone loss, moderate bone loss, or severe bone loss. And of course, it does that both in the tibia and the femur. I thought it was a piece of genius in this paper that they've actually then illustrated them radiographically. So I would commend you to look at that, and I would recommend to EKS to start thinking of that as the system we should perhaps be using in our communications. Now, so that brings us to, if we have those zones or those regions, to stop and think about where fixation can be gained. And this is where a few years ago with Ridgen Morgan-Jones, Sam Musedik, Heiko Greichen, we sat down and decided that this concept that we were talking about at meetings ought to really be put in print and summarized. And you've already kind of heard it in that we break it down quite simply into the surface, which is zone 1, the metaphysis, which is zone 2, and the diaphysis, zone 3. And this has led to this famous diagram that Ridgen produced that people now reference in terms of breaking down these zones. I'm pleased to say that others have now adopted this nomenclature and this terminology, and I think we need to keep talking on that basis. So let's drill down into the zones. I think zone 1, everybody is familiar with. What we're trying to do is get a flat surface or flat cuts. They may not be at the same level. We can augment defects, and if it's less than 5 millimeters, that can be cement, otherwise bone graft or metal. And usually we will fix with cement in that setting and be able to get good, secure zone 1 fixation. The real challenge, but the real key to all of this, is the metaphysis. The metaphyseal shape will be familiar to all knee surgeons, but we need to find a way in the metaphysis of reconstructing those central defects in particular, but also often cortical or uncontained defects. And that's where the world, I think, has moved on from cement and bone graft, still used sometimes, but largely towards sleeves and cones. So we're going from a traditional reconstruction more towards the use of sleeves or to use of cones like this as the new standard of care for revision knee arthroplasty. We'll quickly jump to the diaphysis before we come back. I think the diaphysis is fascinating. It's something we haven't spent enough time thinking about, although people have argued about it. You can, of course, go cemented or cementless. A lot will depend on your bone quality, but getting good fixation in diaphysis can be tricky and is associated with problems that you'll all be familiar with, from fracture to stem tip pain to loss of proximal flexibility to stress shielding, and of course difficulties with revision. So it's by no means straightforward in the knee relying on the diaphysis, and that's one of the things that has led us to emphasize the metaphysis over the last few years. As a warning and as the reason as why we should be focusing on the metaphysis, beware all these stem issues, because you cannot just fix in the diaphysis alone. A knee is not like a hip. If you just rely on the diaphysis, what will happen over time is you'll get windscreen wipering and failure, and then you'll be left with a tricky reconstructive problem that you have to come back with. So, we cannot just rely on that zone 3. Zone 3 is an adjunct that we still need to work through and develop our methods in. And I think there is a lot of development to do there, but you've got to be getting fixation elsewhere, because inadequate fixation will lead to failure. So the focus for most of my presentation is the metaphysis. I think that is what the really clever people started to solve initially with sleeves. That sleeves undoubtedly came before cones, and it was a subset, if you like. It was 1/4 of our community that adopted that based on their industry preferences, but that made a big difference to the ability to get fixation in the metaphysis, and they had good success rates as a result of that. And I think they are to be commended on moving us in this direction. And fascinatingly, this has got to the point, and these are a couple of Heiko's papers, whereby the reliance on zone 2 in certain people's minds is so great that they're willing to disregard putting anything in the diaphysis. I think that's a great topic for discussion and something we should really focus on, but it's fascinating as an example of the importance of zone 2. For me, what's really changed this game is the advent of the cones, because these really have allowed multiple providers to come into the market and has made it something that works with multiple systems, doesn't make you slave to one system. To my mind, the idea here is to get a press fit of something that's got biological potential into the metaphyseal bone and get that sealed in place there. It should have osteoconductive properties to allow ingrowth. That's really the big thing not to go away from. Remember that this has to be biologic. You may get secondary fixation either side of it, but the key is this should become biologic, and you need to bridge that time while the biology heals, and then you can cement around it and do what you need to do depending on the construct. And of course, cones come in all sorts of shapes and sizes and are still evolving. I think we didn't get it right in the femur for a long time. We may still not have it right. A lot of us were using tibial cones in the femur not that long ago. So I think the femur's getting better. The tibias, where it really solved some tricky and really tricky problems, like you see here, where often we're even dealing with relatively unsupported, uncontained areas. The beauty of this form of metaphyseal fixation is it's, I think, technically straightforward. It's something you can teach residents and fellows very easily. I cannot stress enough that it's biological. It is substituting the bone. It's giving you fixation in zone 2, and it helps you correct alignment. And if you're thinking straight through the case, it will help you restore the joint line and potentially reduce the constraint you need. We've certainly reduced the length of stems that we use with this kind of cone fixation. So you see loosening and lysis, hopefully something we're seeing less of, although the bad poly epidemic that's come through as one provider recently has meant, I think, that some of us are having to deal with these things again. Here we can get zone 1 and zone 2 fixation. Frankly, I don't think the stem and the tibia here is doing very much. This is zone 1 and zone 2 fixation. This is a more complex case. This is one of Michelle's refailures, if you like. It's a previous revision that's gone wrong, and by getting metaphyseal fixation, we can resolve that problem. People have taken this to a really fine art. This is a paper from Matthew Abdel's group at the Mayo Clinic, where they're impaction grafting the diaphysis and then reconstructing around a cone. So this is something that really has matured over the last decade, but I think will continue to evolve. There are very few comparative series, and I think in reality both are good solutions. This is one paper from London, Ontario. It's just a comparative study, so I think there's not much to take away from that other than to say that both techniques can work in the right hands with the right thought processes around them. This is a table that we've created, and I'll just take you through it quickly, just to take through advantages and disadvantage of each. I think as I said to you already, the beauty of cones is that there are several types. You can go between systems, you can use different cone types. Some you can actually have a reasonable workflow and work through the cones. You can reconstruct the metaphysis independently from anything else, and you are not slave to the stem, which is quite an important thing. There are increasing myriad designs and shapes and sizes, so you can play with them if you like. For the hip surgeons in the audience, very much as we do with the augments in the hip, you can be very creative, but they can be really tricky to remove, and anybody having to grapple with one in revision surgery will tell you it's a hard day when you've got to remove an ingrown cone. The sleeves work extremely well, and they've got the longest track record, but there is no cross compatibility, and there's a Morse taper here, and the sleeve and the stem will dictate that implant position, and they are symmetric, so they don't give you some of the flexibility. We haven't seen much in the way of junctional failure, but it does exist, and they can be difficult to remove. Just jumping quickly to the diaphysis, I think that's an area of great debate, but that's also an opportunity for development. We are still thinking about whether it should be cemented or cementless. Some people have very strong views about that. We tend to use cement more and more and tend to go for shorter stems rather than longer stems. And I would say, in terms of thinking about the diaphysis, beware isolated stem fixation. I've already shown you that that doesn't work in the knee. Also beware being slave to the stem. You then are committed to offsets and doing all sorts of things to get the proximal tibia in particular to fit, and that may create problems with metaphyseal fixation. Always think about the next operation. Really tricky if you have to remove a very distal, very long stem. And also, I think there is an overusage of long stems just as something that makes surgeons feel better by sort of half filling the diaphysis. Because they've had to ream down there, they put something down there without getting good fixation. So again, we've got to be careful that if we're putting something in, it should have a role. I think there are advantages and disadvantages to both cemented and cementless fixation. I've given you my bias towards cemented stems in terms of being able to go short and not be slave to the stem. We can also deliver antibiotics with them, but a cemented construct can be tough to remove. There's no question that going hybrid with a cementless stem can work well in sclerotic bone. It may give you better long-term fixation for some patients, and it helps with your alignment. I think the reality is we haven't solved a lot of those problems. They're still up for debate. The reality is most revisions required a combined approach to reconstruction, and I would beg for a multi-zone strategy. You should really be getting good sound fixation in at least 2 zones, one of which probably should be the metaphysis. That's the real key. Getting ingrowth in the metaphysis is big. So in terms of surgical planning, which zone or which zones are we aiming for? Which reconstruction strategy are we going to use on each side? Which fixation method? And then last but not least, getting the joint line right. And I think you can't do any of those things I've mentioned without remembering that you have to plan and deliver the joint line. In the femur, often you have to go distal and posterior, in the tibia proximal, but it would be daft to be so focused on the fixation as to forget that. So there are lots of hints, tips, and tricks as to how you find that, whether it's the old meniscal scar, relationship to the fibular head, looking at the other knee on the x-rays, one finger below the patella if you don't think you've got a patella baja, or probably most reproducible distance from the medial epicondyle, but you need to work through those and deliver that. So I think in summary, revision knee arthroplasty has evolved and is continuing to evolve. I've kept this relatively simple, and I hope the discussion with Professor Van Hellemond, Professor Baldini, and Professor Bonin-Lustig may take it to the next level, but there's no doubt that there is still more work to do here. I would commend this classification to you. I think it is a better classification in terms of research and in terms of our communication than AORI, because it will encompass many more of our cases and be able to differentiate when you're looking at complexity. I don't think zonal fixation will go away. I think that is the future of knee reconstruction. So we should always plan in terms of zone 1, zone 2, and zone 3. Think about the epiphysis the metaphysis and the diaphysis in all cases. So in 2022, I'll repeat, most revisions need a combined approach. You've got to be prepared for the worst. We need a multi-zone strategy, and the metaphysis will continue to be key, but I think we've got work to do even within that and on optimizing the diaphysis. Thank you very much. I hope I've now stopped sharing my slides.
We lost Michel.
Yeah, I'm here. Oh, yeah.
Is it all right if I start with a question to Faris, or do we wait for the audience to come up with a question?
No, I'm on the chat, so I'm gonna pick the right question. So please start. Please.
Okay, Faris, thank you very much for your presentation. There was a small question I have regarding the Zone 2. I think all industries come up with a sort of new device, and we all know that our baseline papers will be on sleeves and cones with tubercular metal. And now you see these on-growth small central metaphyseal fixation type. Should we worry on uncontained defects and getting small rings into the metaphysis and rely on those, or is that a biomechanical failure?
No, it's a great question, and I think there's several layers of answer to that. I think the first one is that we coined this expression a few years ago that heritage must be earned, and in reality, the minute you change something, you need data. So whilst the principle is right, going from central to peripheral, going from contained to uncontained needs data, and people are gathering that data, and that data's out there. In parallel, I think this is something that has morphed with very little clinically engaged biomechanical work, and that work is now happening because people are trying to figure out what is or is not possible. Because as I go around now, different parts of the world have evolved to a different degree. I still grapple, for example, in some parts of the UK with people still not even addressing the metaphysis when they're doing revisions, whereas I see some parts of North America where really crazy things are being done with unsupported cones, which I think are likely to fail and could be lumped together and cause us a problem. So I think the answer to your question is that every time we make a change, we have to collect data. Does that make sense?
Yeah, it does make sense, yes.
And that's why in research, classification, coding are going to be key in this area, because having everything lumped in a type 2 isn't going to help anybody.
Yes.
One question, Faris, regarding offset. You mentioned briefly offset, and how does it go together with the Zone 2 fixation and the need for offset? And do you think there is really so often need for offset stem, or is it only for a very special situation?
So I think it's interesting, 10 years ago, I think we were using offset stems more and more, and we were basing our workflows around the stem. And then we evolved towards basing our workflows much more on the metaphysis, and we've increasingly not used offset stems. It's very tricky to use an offset stem beneath a cone. And also, you guys are all big revision experts. Revising offset stems can be an unpleasant thing to do. So certainly we've moved towards cones and short cemented stems for that reason. Now, that's one of the advantages of using a short cemented stem, is then you don't face that perplexing tension between your stem wanting to be in one place and your metaphyseal fixation wanting to be in another. And that's something we still have to grapple with. But some of the workflows now where you're working your distal tibia or distal femur through your cone are really helpful.
Another question regarding Zone 3 fixation, and you mentioned the cementless option, and you understood that your favorite one is more regarding short cemented. Do you think we should move completely away from cementless, or there is still something we should consider, or are there specific indications?
No, I think there's a lot to work through there, and I'm slightly. I should be shy here because obviously Geese has done some of the work on this over the years. I think there are still indications for both, and it will partly depend on what your metaphyseal diaphyseal mismatch is, how you're going to manage both. But I think there are occasions where you're going to need to get fixation in the diaphysis, but then you genuinely need to be able to get ingrowth fixation in the diaphysis. And I think there's a lot of work to do based on some of the stems we've had in knee revision surgery. There's still a lot of improvement to do, would be my perspective on it. But it's probably worth getting a comment from Professor Van Hellemond, who's done some of the studies trying to compare these techniques.
Well, I think this is typical a discussion which is more or less case-based, I would say. If surgeons say, I always cement, I always ask them what they mean by always. And I think if you talk about uncemented in a re-revision, you need to have some secondary fixation. And the question is, if you use secondary fixation or on-growth or ingrowth or Wagner type in zone 3, you have to ask yourself the question whether it's revisable. If the ingrowth will take place, we all know getting out a Wagner stem is a very difficult thing. The other problem I think is very important to know, if you say I always cement, if you have a re-revision with sclerosis, it's probably not a good idea to put cement into the zone 3 where there's already been a stem in. So I would suggest that we try to find out the reason why sometimes an uncemented stem is a good solution. If the diaphyseal area has not been used, you can make your choice. If it's already been used, look at it, whether it's sclerosis or not. And that's the reason why the Mayo Clinic came up with the idea of bone impaction, which actually we use as well, because then you can use cemented stems with a combination of bone impaction. But that's different as saying always. I would suggest not to use the word always in re-revisions.
But don't you think that the problem of the stem is that we speak only in matter of length and in matter of cementing or non-cementing? But the design is also very important. And an uncemented stem is not the same design of a cemented stem and vice versa. Cemented stem should be conical to increase the pressure of the cement progressively. And now we have, the offer in stems designed to be cemented is very low because most manufacturers have switched toward a uncemented stem cylindrical.
Yeah, I think you're absolutely right, Michel. That's fundamentally the problem. Is we still need to evolve what we're doing there and why. So I agree with Geese. I hope I didn't say always in my presentation, because we don't always.
No, you didn't.
We don't always do anything. No. we probably always get it wrong, but nothing else.
We have a question in the chat. With always, by the way, should we always use a stem in sleeves or cones?
I mean, the answer is not necessarily. We've seen that from Heiko's work. I think you've got to think that you need to get two-zone fixation. That would be, and people, I say this guardedly because some people would argue with me now that they've gone so far into the metaphyseal world that if you get the metaphysis, they think everything is perfect. I think we've got to be a little bit careful. I think you need two-zone fixation. So if you have zone 1 and zone 2, I'm not sure you need very much in zone 3. Now, whether that translates to a short stem, cemented or cementless, or nothing like Heiko's done, that's open to what you feel comfortable with. I don't think it looks that good, so I tend to put a short stem in, personally.
And Heiko is published on sleeves.
Yes.
Are there some publications on cones with no stem?
I have not seen one, if I'm honest, but I've seen them at meetings. So I don't know if, I've certainly seen that at meetings, and I've seen cones like that used in primaries with little stems with stubbies. So I think I suspect people are doing that, but I have not seen a paper.
I think, Andrea, you used it as well, huh?
Yeah, no, with a 60, not with a stubby. I haven't used it without stems. And I would like to expand this question in saying that if you use a cementless fixation in zone 2, like a sleeve or a cone, we should be aware that cement from zone 1 shouldn't penetrate in zone 2, because when you do re-revision, you see in many cases particularly if you have let's say sleeves also integrating only in the first 2 or 3 steps, occupied by cement coming from zone 1. The same for the cones, and particularly we are now changing our technique of using a cemented stem in a cone, because with the plug and retrograde technique of cementing like we do in the hip, we are getting a lot of cement behind the cones from back to forth, and this is then limiting the ingrowth of our cones. This is something that we see in re-revisions, of course, but sometimes on the x-rays you think you have a pristine cone or a pristine sleeve, but in reality, if you do dissection of these cases, you may see that there are cement around. And this is one consideration. The second consideration is, I think degree of constraint may play a role in answering that question, because we have to think that the zonal 2 fixation with a cementless option is working when you have ingrowth. But if you have a hinge, for example, as I have seen, without stem, it means micro motion from the beginning, and this does not allow a cone or a sleeve to osteointegrate because the degree of constraint is too much.
And when do you say changing the cementation technique? How do you do? Because if you moved away from the plug and the retrograde cementation.
No. We still use a plug. We are, I mean, is an expanding area. We haven't find the perfection so far, but we are doing some bone impaction retrograde with a T handle to fill the interface between the bone and cement, and to be sure, because most of our cone in the femur, for example, are conical, and the preparation may leave a wedge of unprepared bone, and this is a good cavity for cement coming back. So we make sure cement far from you, bone far from you on the cone, inside in the canal is really filled of bone and not with a void.
Andrea, have you seen failures of cones on that basis? Because intuitively, I share your concern and I can see how that happens. But my perception would be, as long as you have a good press fit and an osteoconductive surface that is opposed even in 30%, 50%, 60% of that surface, that probably is going to deliver enough ingrowth to give you a stable construct. Or do you think we're actually seeing failures because of cement ingress into that area?
I have seen failure only in disaster cases, in re-revisions mainly, where the support around is limited. And I have seen more failure in this aspect in sleeves with 2 steps only osteointegrating, because in Italy, my country, the fully osteointegrated sleeves came very late, and we had only limited osteointegration in the sleeve for a while, and I have seen failure in that cases occupied by cement.
Yeah, it's the same in our country. We saw some failures where there's a large uncontained defect. So if you have them enough inside the bone, it's okay. If you allow them to have a little bit undersurfaced of the host bone, then it's probably a risk. And
Yeah,
of course, some people who use the sleeves, they say...
I have a question for Fares. Sorry.
Yes, please,
Sorry.
Andrea.
Fares, do you see a role in zone 2 for cement anyway? Because we know that, for example, cementless fixation is mandatory when the bone is sclerotic, but in several occasions we still have a medullary bone in zone 2. Do you see that zone can be occupied by cement in a proper way, and if you are still cementing zone 2 in any case, or you are using it in every case a cone or a sleeve?
So I think I cement zone 2 in primaries. It's if you will forgive that, but I think that's quite an important thing now in terms of how we get primary fixation for I think in revisions, I think it's tricky. I mean, I think you can do that, but then you're relying on the diaphysis, and I'm not entirely persuaded that that's a long-term successful strategy. I think that the beauty of getting zone 2 right is the ingrowth, and it's getting that stability in the longer term. So I hear what you say, and there is often cancellous bone in zone 2, but I think in my practice, in a revision situation, we are typically going to put a cone in zone 2 unless it's a very minimal bone loss situation.
Well, the only exception I've heard talking about this subject in countries where there's no cone or sleeve available, sometimes they cement in well, let's say, good spongious bone a offset. If you have an offset with cement with enough, let's say, interdigitation of cement inside zone 2, that might be a, let's say, a possibility if you don't have zone 2 additional ingrowth options available.
And yeah, true for the tibia and the femur, or do you make a difference?
I personally don't make a difference. I think offset itself is, of course, very difficult to remove if you have a fully cemented stem. I never do that. There's no need to fully cement your stems with an offset. But if you just cement, as Andrea said, the surface and zone 2 with an offset, with an uncemented stem, it will give you some additional fixation in zone 2.
But in those cases, you're getting a very good fit in zone 3, I assume.
Yeah.
I mean, I think that's you're getting zone 3 fixation.
Exactly.
We have one question about surface fixation. I suspect it's regarding cones or sleeves, and asking to elaborate a little bit. I suspect on the process and the time it takes.
So I wasn't sure whether surface fixation was zone 1. It could be. So that's also a surface. But in terms of cones and sleeves, I think we've learnt from numerous studies over the years that ingrowth is going to happen somewhere between 6 and 12 weeks. So you've got to protect for that kind of period at least, and get sound fixation across it for that kind of period. I think we get ingrowth reasonably quickly.
And when you say protect, you mean wide bearing or limit range of motion?
No. I think you just got to get fixation. You cannot just rely on the cone or on the cone during that time period. You've got to have good enough surface fixation or good enough zone 3 fixation in order to allow that cone to ingrow, which is why I agree with Andrea. One of the real challenges with hinges is both actually getting them through with something in the metaphysis that's giving you metaphyseal fixation, and also not putting too much force through the area early on. I think that's a tricky thing to deal with.
So maybe to ask Andrea on that, what about, let's say, options in zone 1 for uncemented use? I know you once in a while use an uncemented trabecular metal wedge in zone 1, Andrea?
Yeah, we have done this extensively, even when it was off-label, tending to expand fixation at that level. I'll tell you, watching the cases back, that zone is much less strong than zone 2. Sorry. So zone 1 at the maximum level you can expand this fixation. You will never get the biomechanical strength of zone 2 because it's a surface against a cavity. But I think it's very useful when we pass 15 millimeter augments, because you miss rotational stability on the condyles, on the femur, for example, even on the tibia. If you use thick augments on the surface more than 10-15 millimeters, you lack rotational stability of your component. And dividing this fixation, when some part can go directly on the bone with a trabecular metal augments, for example, and the rest is on the implant, we may lose less than what we are losing with just filling a piece of metal in your component. And the same for the tibia. You lose the keel rotational stability once you go higher and higher with a regular augment. Augments are against fixation, the titanium augments. They are just bone filling devices, and joint line finders, but not fixation devices.
So those are probably also strong indications for the use of a cone anyway, yeah? Because that's most of the surgeons, question in surgery. When do you need to use them? And I think you're absolutely right. Full wedge under the tibia of more than 10 needs to have a zone 2 fixation. And the same if you have more than 10 millimeters of distalization of your femur, you lose the box, rotational stability, and then a zone 2 fixation is mandatory. Yeah?
So
Yeah,
we
in
wouldn't
fact,
we wouldn't use more than 10 ever. I have to say, I'm going to say and always, because I don't think we wouldn't go more than 10. Sorry, Andrea, I interrupted you.
Yeah, I mean, the definition of zones is not completely clear. Where the epiphysis is ending, the metaphysis is beginning. Where the metaphysis is ending and the diaphysis is beginning. There is not a deep science on it. We are collaborating with HSS now with a study on it, and with artificial intelligence. We are using the square rule by AO, where you measure the width of the bone, and you use the square rule like Mueller was doing for AO fixation, in order to give some reliable measurements, because the metaphysis, we all talk about metaphysis, but where the metaphysis is exactly finishing and when the diaphysis is starting is an interesting concept, because even it reflects on design of our devices.
Exactly.
No, and you do have devices that fail at that junction, or
Yeah.
where I perceive that junction to be, which makes a tricky reconstruction.
Yeah. Maybe there is also a fourth zone, which is a metadiaphysial passage, particularly in the femur, because that conical area in the femur is not fantastic for a stem, we know, and is far to reach by some other devices, unless you are using a double cone, for example, or a long sleeve.
And that's also what you saw in the paper by Heiko, that the sleeves are relatively long if he
Yeah.
uses them without any stem. And some of the other designs, which are not the sleeves, they will be too short to be unsupported without a stem.
Yeah.
Agreed.
We have final questions about stem. Because you mentioned short stem. How do you define short stem? And when is it not short anymore?
So every system, as you know, every system will have what is available stem-wise. So I mean, the shortest will be 30 millimeters beneath the cone. It'll be a very, very short stem, but it depends on which industry partner you're working with and what the shortest they provide is. So our short stems go 30 beyond the tip of the cone. So it's a 60 millimeter stem.
Chris, Andrea, you have the same definition for short, or about the same?
For me, a short revision stem should be a stem which enters in zone 3. That means it should pass zone 2. And I consider zone 2, as I told you, with the square rule of AO, meaning metadiaphysial passage, you should at least reach that. In most of the cases, with the system I'm using, that means I need a 60 stem. 60 plus 40 is 100. So that is my short stem. And I would say almost both for tibia and femur, something different for female and man, because for a man, a 60 can be still a very short stem, still in zone 2. Still navigating in the medullary of the metaphysis.
And you would go longer in the femur than the tibia, wouldn't you, Andrew?
Yeah, because my impression is that at least the tip of the cemented stem should go relatively close to the cortex. Otherwise, if it's dangling in the medullary canal, that is a low resistance device against varus valgus forces.
So for us, we do 75 in the cemented ones, calling it short, and 160 in the press fit hybrid.
but 75 combined or isolated?
Isolated.
So
that's
it's
on top
plus
of
40.
Yeah.
Yeah.
That's quite long.
So we have another question regarding bone grafts for reconstruction of zone 2. You briefly mentioned it, and they want to know if you have any tricks to contain the graft and prevent it to fail in zone 3.
I think the Mayo guys have, what they've done is pretty clever. So I think if you are grafting, I'm typically cementing a stem beneath it. So as long as I'm trying to contain the graft, I don't have any clever tricks other than just grafting before I put the cone in, then grafting again after I've put the cone in, would be my perspective. I don't know if anybody's got a good way of retaining the graft, but if any slips into zone 3, that's not a disaster per se.
So I tend to put my stem in and then bone impact it through a specific set we have with an open tray. So it's an open tray where we can actually put bone graft from the top around the stem, then put zone 2 fixation in, and then more or less you are safe. And allow some play for the diameter of the stem you put in and the cemented stem you're actually going to position. So if you want to put a, let's say, 12 stem in, I do the bone impaction with a 16 stem in zone 3. Otherwise, you are over-pressurizing, especially on the tibia, which is dangerous.
No, makes sense.
Andrea, other tricks?
I would say I'm coming from a difficult week. I've done re-revisions after multiple infection, and I had to remove cones deep in the metaphysis. And I was asking to myself, maybe in these difficult infected cases, probably we should go back and use more bone as well, because we have to always think about a plan B. It's very difficult to remove these devices, particularly when they get close to the cortex. I had to open the tibia, the femur. So this is a very destructive surgery, and I think when we are expecting a high risk of failure case, bone impaction should go back.
And I can tell you something more on that. If we do the high-risk patients, I still use a cone which is on growth instead of ingrowth. So if you use a, let's say, different type of design, you can still use a type 2 fixation, but I don't use trabecular metal anymore for that reason. The only reason for me to use the trabecular metal ones are the uncontained large defects, because then the central parts which are on growth are not useful. But otherwise, in those difficult infection cases, it's much more easier to revise a cone which has on growth instead of the trabecular metal ones.
I guess, do you think having said that, and I think that's a good rationale, do you think your trabecular metal is giving you something the others aren't giving you, given that they're getting that initial on growth?
Well, I don't use the trabecular metal one with on growth, but different design, which is easier to get access to if you really want to take them out. We all know that trabecular metal, which really is in growth, especially as Andrea said, when it goes a little bit because of the design through the cortex, those are nightmare cases.
Yeah.
So if they have a higher chance of a reinfection, I try to use the on-growth type, which is of course a titanium ring with on-growth stick tight, but that's a different design and easier to remove for sure.
And you can use it for both tibia and femur?
Yeah, you can. And then you use bone impaction in zone 3, and then they're still revisable. And for that reason, I also stopped with using the Wagner type of stems in zone 3 in a case where high infection recurrence is likely, because then you have to really, think about how to remove it, because it's almost impossible.
Yeah, that's always the discussion between wanted to get good secondary fixation and what's going to happen if you have to remove them. Just like Andrea said, then you have a very bad day.
Well, I mean, that's why we should not say we always use, I mean, we have different systems available. And I think it's very useful, especially in your re-revision and infection cases, about different systems which have different advantages or disadvantages.
Michel, I think we went through all the questions in the chat. I don't know if you want to
Yeah, it's great.
conclude.
I think that what is important to understand is that in revision, even more than in any surgery, the surgeon becomes the slave of the instrumentation, as said Ferres. Not only from the stem, but we are the slave from the instrumentation, which is very complex. And revision is a surgery; it should be intuitive, and when the instrumentation is too complex with too many devices, it's very difficult to manage.
Tricky, because I think the generation before us and our generation has taken revision from being an art that
Yeah.
very few people can do and translated it to something that many people are doing. Whether that's right or wrong is another matter. And I think that has been done through instrumentation and through workflows and through the transference of knowledge from, from Gies and Andrea and others who are thought leaders here, to be able to get the guy who doesn't have access to big volumes to be able to do stuff. So I think we face a real challenge unless we're going to centralize revisions worldwide. And that's tricky. That's a very painful journey we're on in the UK that I'm not sure you guys want to share with us.
But Michel, as in the French paradox, the French paradox on wine, as in this paradox, my paradox is that I use less instrument in my revision than in primaries, because if you escape zone 3 and you stop using strange instrument for the offset and use zone 2 fixation, just the shadow of the components of the trial and short cemented stems, you end up with less instrument with revision.
Yeah, of course. Yes, I
with
have
a straightforward revision.
Yeah, it's what I use also customized box with nearly nothing, and it should be very intuitive. But the problem of revision is that generally the reps arise with 20 bucks, put the 20 bucks, and nobody knows how to use it, neither the scrub nurse and nor the surgeon. So, and this creates the difficulty. So I fully agree with you. We should have very small box of instruments so that the surgery is very intuitive.
Well, but I think it's also part of what Faris said in his talk, and what I know Andrea is doing a lot is pre-planning. Just don't go in with a lot of sets, because you become slave of your instruments and you have to think intraoperatively. And I'm afraid that still a lot of surgeons go in without a real plan what actually will be executed. And I think that's probably the main message. If you go in, think what you want to do, where the joint line needs to be, and what type of fixation you want to get at to. If you don't do that before surgery, I'm afraid you will end up in trouble.
That will be the word of the end. Modern surgery is done before the OR.
Yeah, I'm afraid so, especially in those revisions.
And will be more so. That's the future. Better planning.
Michel, you want to introduce the next EKS, your hot topic?
Well, the next hot topic will be dedicated to patellofemoral prosthesis. The speaker will be our president, David Barrett, with two experts. I think there is you, Seb.
Yeah, could be.
And the date, it will be the December the 5th. Okay, and the last expert will be Manu Tienpant also.
Looking forward to it.
So we could thank everybody for being here. Thank you very much to the speakers, to the experts with this very fascinating discussion. And thank you to all the attendees. And so we'll see you back in next month.
Thank you very much.
Thank you.
Thank you, guys.
Bye bye.
Bye bye.